Buenas tardes. Es para mí un verdadero honor presentar al doctor Mark Mannis. Es la primera vez que lo tenemos aquí con nosotros en el Centro Mexicano de Córnea. Bienvenido, doctor. Todos sabemos la gran trayectoria académica que tiene el doctor Mannis. Él es egresado de la Universidad de Washington en San Luis, Missouri, y hizo su residencia en la Universidad de Iowa en Iowa City. Pertenece a diversas academias, a diversas sociedades, entre ellas la Academia Americana de Oftalmología, ARVO. Él es profesor y jefe de oftalmología de la Universidad UC Davis Health System Eye Center. Es una persona que ha estado involucrada en el desarrollo de agentes antimicrobianos y factores de crecimiento que interfieren en la cicatrización corneal. También en diversos padecimientos sistémicos, sobre todo de la piel, que involucran el globo ocular, así como estudios sobre el trasplante de córnea y córneas artificiales. Es autor de más de 125 artículos, de 5 libros. Y bueno, nos sentimos muy honrados, doctor, de tenerlo con nosotros, y le voy a pedir que pase a presentar su lectura.
Thank you for that lovely introduction. My mother would have been very gratified, and my father would have believed about half of it. Nothing could give me more pleasure than to there we go. Nothing could give me more pleasure than to give a lecture in honor of Professor Enrique Graue. I've known Enrique for many years. He was a predecessor and a mentor in my career in the Pan American, and his presence has been constant in the leadership of Latin American ophthalmology. Of course, in Mexican ophthalmology, he has been president of the Sociedad Panamericana. I would love to spend the first 20 minutes of the talk reviewing his 123-page curriculum vitae, but I think that's not my job here. I do want to share a couple of my personal impressions of Enrique. He's a man of great intensity. He believes in causes deeply and profoundly, and is not afraid, even in the face of complicated Latin American politics, to say his piece. Despite that intensity, he's also a man of great warmth, who embraces his fellow ophthalmologists, his friends, and of course his family with huge enthusiasm. There's probably nothing more important to Enrique Graue than his wonderful family, whom you see here, and particularly his 2 grandchildren, seen here, over whom he dotes without any shame. He is a tremendous grandfather, and as someone who just became a grandfather this past Monday, I look to you as my example, Enrique. Enrique's greatest gift to me was his son, who he loaned to me for a year, and we had a tremendously productive time in Sacramento, and Enrique Jr. has gone on to, in his father's footsteps, and is clearly an emerging leader, not only in Mexico, but throughout Latin America and in the Western Hemisphere. So it is really an honor for me to give this lecture, and a great honor for me to have both Enriques here in front of me. So thank you for inviting me to do this. Keratoplasty, as I pointed out yesterday in my talk in the other room, has undergone tremendous evolution over the last 4 decades. And what we did in 1980 is not at all comparable to what we currently do for the same group of patients in 2012. Penetrating keratoplasty has been a very successful operation for us. For over 100 years, the penetrating graft has been the mainstay of corneal therapy. Yet we all know that the problems with penetrating keratoplasty include lengthy healing times, which are problematic both for the elderly who have little time to spare and for the very young who are taken out of the workforce during this healing period. The visual recovery is therefore also slow. There are consistent problems with high and irregular astigmatism, regardless of the expertise of the surgeon. There are problems with immune rejection, endothelial graft rejection, and there are the persistent problems of glaucoma and cataract. And so what has evolved is the concept of selective keratoplasty, replacing only that portion of the cornea which is diseased. By doing this, we perform less surgery on the patient. There's much more rapid visual rehabilitation. The quality of the vision is better. And importantly, the donor base has been greatly broadened by the use of selective keratoplasty. Along with this, there has come a new terminology, and we're all familiar with posterior lamellar keratoplasty, deep lamellar endothelial keratoplasty, Descemet's stripping endothelial keratoplasty, Descemet's stripping automated endothelial keratoplasty, and Descemet's membrane endothelial keratoplasty. So these are all an alphabet soup of procedures which have developed as we develop refinements in our technique. So in the next 20 minutes, I'd like to talk about endothelial keratoplasty from the simple to the complex. Assuming that most people in the audience are corneal surgeons, I'll try to provide you with some of the nuances of this surgery which make it successful. I think everyone knows the primary steps of endothelial keratoplasty. The first is the outlining of Descemet's membrane, then the stripping of Descemet's membrane. Here you can see roughening of the internal stroma to help keep the donor in position. The donor material, which is prepared either by the surgeon in the operating room or more commonly in the United States by the eye bank, is then placed in the anterior chamber with a variety of techniques. And these techniques have proliferated, beginning with this type of fold and stuff technique to a variety of pull-through techniques, and then a new proliferation of instruments which are designed to insert the button atraumatically. Once the button is inserted and unfolded, air is placed in the anterior chamber, and as the endothelium begins to pump fluid from the stroma, it becomes adherent, and the procedure is complete. So that's the basic surgical procedure in which we are replacing only the endothelium with a stromal carrier. Endothelial keratoplasty obviously works for posterior corneal pathology, and I learned yesterday, to my surprise, from Enrique that Fuchs dystrophy is relatively rare in Mexico, whereas in the United States it's probably the most common indication for keratoplasty, along with keratoconus. The endothelial keratoplasty avoids all of the problems that we mentioned with a penetrating graft and improves both corneal clarity as well as rapid visual recovery. There are several key steps in this procedure which can signal its success or its failure. The first is the stripping of Descemet's membrane. This needs to be done meticulously and completely, since retained Descemet's membrane can produce unwanted optical results. Insertion of the button becomes very important, and we'll talk about that in a few minutes. And then a variety of ancillary procedures, venting incisions, roughening of the bed to ensure adhesion, a 90% fill of the anterior chamber, and then, importantly, post-surgical management. So those are the key points at which the procedure can become successful or unsuccessful. Here you see in this film the way we currently insert the button. We do not fold and stuff, but rather use a sheets glide. Here you can see the button is brought to the glide and then simply pushed into the anterior chamber with a needle. This avoids any trauma, any significant trauma to the endothelium. And in addition, it avoids all of the expense associated with complex inserters. So I think that this methodology not only works well, but is very cost effective. Here you see it again. The button is put into the anterior chamber. The chamber, before unfolding the button, is then closed with 2 sutures. We actually use a butterfly-style suture in our practice now. And then fluid is placed in the chamber, then air, and the button is in position. It's a very atraumatic way of inserting the button that requires no special instrumentation. Fenestrations have been somewhat controversial. Fenestrations are 4 venting incisions that are made through the cornea to allow fluid to exit from the space between the donor lenticule and the back of the cornea. This was introduced by Frank Price and has been the subject of great debate. Of the 2 corneal surgeons who do DSEK in our department, one is a very avid advocate of these venting incisions, and the other one is a very avid opponent of the incisions. I, of course, am right. The removal of interface fluid is extremely important at the end of the procedure, and also roughening of the peripheral stromal fibers to ensure graft adherence is important at the end of the procedure. An air bubble is placed and is left there for 24 hours. We generally put an 80 to 90% fill in and dilate the patient with scopolamine or atropine at the end of the case. Since we've been doing that, we've had not a single incidence of pupillary block. So it's not necessary to see the patient an hour after surgery and let air out. If the pupil is well dilated and the eye is firm but not hard, there's very little chance that one will develop pupillary block or have a dislocation. What are the complications of straightforward DSEK? Probably the most common is fluid in the interface between the graft and the posterior cornea, as you see here. This must be repaired on the first day by a rebubbling. Prayer does not work. It's very difficult when the patient comes back the next day and you have 60 patients in the queue and the patient comes in with fluid and you say to yourself, well, maybe we'll wait till tomorrow. The fluid will reabsorb. It won't reabsorb. So you need to rebubble the patient on the same day. This can be done easily in the office with a 30-gauge needle and is usually quite effective. Here you can see a dislocated button. The button becomes edematous. By putting air back in the chamber and repositioning the button, the cornea will clear within 24 hours. Graft rejection does occur in DSEK, but it looks different from the graft rejection that you see in penetrating keratoplasty. Because of the donor is elevated above the plane of the posterior cornea, one does not usually see a cotaduce line like you would see in a classic graft rejection, but rather usually low-grade inflammation and scattered keratic precipitates. This does need to be treated vigorously, but is usually reversible. What about DSEK in more complicated situations? In the case of cataract, again, in the case of glaucoma, let's discuss each of these briefly. Some advocate performing cataract surgery and then coming back later and doing DSEK surgery. I'm a great advocate of bringing the patient to the operating room as few times as possible. So if one can perform cataract surgery with a degree of corneal edema present, then we perform phacoemulsification with lens implant and then proceed directly after that to DSEK. It calls for modifying the incision slightly, but it's very easy to do. In rare cases, we remove the epithelium if there's substantial bullous change, which would hamper the performance of the cataract surgery. The incision location for combined cataract DSEK surgery can be either superior or temporal, and it can be either clear cornea or near clear. We generally use a near clear scleral incision in the base of which we make the incision for the cataract surgery. It's very important when you're performing phaco-DSEK to recalculate the lens implant for the additional corneal thickness. And so we generally err on the negative side of -1 to -150 to approximate a planar refraction at the end of the procedure. I strongly advise against using toric or accommodative lenses, but rather use an aspheric monofocal lens for these cases. There's a variety of literature on lens calculation for DSEK with cataract, and I commend you to the papers you see in front of you. Very important when performing cataract surgery and DSEK to use a cohesive rather than a dispersive viscoelastic. The reason for this is that if you use a dispersive viscoelastic, the button will not stick. It's difficult to get the dispersive viscoelastic off the cornea. So that's very important. Also, in an edematous cornea, if there's any question, we strongly recommend the use of Vision Blue, which helps you visualize the anterior capsule during the cataract operation. We also recommend a smaller capsulorhexis, which will allow stabilization of the lens implant during the time that you're in the chamber, removing viscoelastic, putting in buttons, adding air, etc. What about doing DSEK in a patient who's already had cataract surgery and has an anterior chamber lens? The presence of an anterior chamber lens is problematic in the sense that it lessens the degree of latitude that one has in manipulating the graft. There's less room in the anterior chamber. So it adds additional operative time to the procedure and some intraoperative risks. One can produce anterior iris and anterior ciliary body trauma by pressing down on the lens. And the air bubble management can become very difficult because the air bubble can go behind the lens into the posterior chamber. There's also, of course, greater risk of intraocular lens endothelial touch or touch with the insertion devices. Commonly, when there's an anterior chamber lens, there has been a problem with the first cataract surgery. So if an iridoplasty is necessary or anterior vitrectomy, these should be done, obviously, prior to the insertion of the device, of the lenticule. Also, one needs to be sure that one has adequate anterior chamber depth. You can see here the 2.22 millimeters from the back of the cornea to the anterior surface of the intraocular lens. That is the usable space one has. So anterior chamber retention should be considered when there is a stable, well-positioned lens, prolonged good vision with the anterior chamber lens, delayed endothelial failure, adequate anterior chamber depth, and in older patients. In a younger patient who is having DSEK, for example, in a 40-year-old who's having DSEK, I would probably remove the anterior chamber lens and put in a transscleral posterior chamber lens prior to the DSEK. Here you can see a specific way of managing the lens. lenticule. The lenticule is placed in the eye, and then when you put in the air cannula is used to push the lens posteriorly as you add air. This allows the lenticule to unfold in a deepened chamber. So the cannula is used for two reasons. One, to put in the air, but at the same time, to push the anterior chamber lens back during the insertion. So with a retained anterior chamber lens, important to get all vitreous out of the way, to use a pupil constricting agent, to place, if there is not one already, a concurrent inferior iridectomy, and it's better to have it inferior than superior because of the bubble will go upwards. If you use a slightly smaller endothelial graft, it's easier to unfold. And by pushing the anterior chamber lens back, you can prevent the graft from touching the lens. And one needs to use a larger postoperative air bubble. What about endothelial keratoplasty in the patient with previous glaucoma surgery? We all know that glaucoma drainage devices, which are probably the most commonly used approaches these days, produce problematic issues for corneal grafts. My own work in this subject with Lenio Alvarenga from Sao Paulo determined that graft success was really only in the 55% range in patients who had either an existing glaucoma drainage device or a concomitantly placed glaucoma drainage device. And even then, pressure control was only at 76%. In DSEC patients who have had glaucoma surgery, as you can see from this data from my former fellow Barry Lee, there is a much higher incidence of a dislocation of the graft in patients who have had previous glaucoma surgery. So glaucoma surgery represents not only a challenge in terms of technique, but there's also the challenge of how you deal with the air. With a bleb or a tube shunt, as with anterior chamber lenses and aphakia or large iridectomies, air becomes a problem because the air seeks the posterior chamber. I would caution those of you who are concerned about elevated pressure that postoperative hypotony is our worst enemy in DSEC surgery, even in the glaucoma patient. So at the end of a DSEC case, in a patient with glaucoma and a known compromised nerve, we still leave the eye fairly firm because of the high incidence of dislocation of the graft. So surgical tips. If you have a filtering bleb, you may need to change the entrance location. You want to avoid overpressurizing the eye and popping the bleb, which we've seen happen. If there's a large surgical peripheral iridectomy, it should probably be closed. And it's okay to leave the eye 100% filled at the end of a DSEC procedure in a patient with a previous trab or a tube, but do not take air out at the end of the procedure, remembering that hypotony is your enemy. Also, if there's a question of overfiltering tubes or overfiltering blebs, these should be corrected before endothelial keratoplasty. Very important to minimize the trauma to the endothelium. Do meticulous wound construction so there's no problem of leaks, suture paracentesis sites and wounds. Normally it's not necessary to do that. In the glaucoma patient, probably a good idea. Watch for overfiltering or leaking blebs and consider temporary tube occlusion with heavyweight viscoelastic. In aphakia, the same problem occurs. Attempts to put air in the chamber, as you'll see here, the air simply goes behind the iris. So one needs to make sure that the air remains in the anterior chamber, sometimes difficult to do. And the problem is the more air you put in, if it continues to go behind the iris, it will push the iris forward and diminish the room for air in the anterior chamber. So, recommendations for complicated DSEK surgery. In glaucoma, consider a temporary tube obstruction. Inject air with a 30-gauge needle instead of a cannula. That leaves less opportunity for the air to exit. Suture paracentesis wounds for a tight seal. Leave a 100% air fill after the case. In aphakia, if possible, place a secondary intraocular lens prior to the EK surgery. It will make your life easier. And very important to make sure that there's no vitreous in the anterior chamber, either in the pseudophakic anterior chamber patient or the aphakic patient. When you should not do endothelial keratoplasty, when the problem is not endothelial. And you may laugh, but I have had referred to me cases in which patients performed endothelial keratoplasty when there was anterior stromal scarring. When there is coexisting anterior stromal opacification, the patient with chronic scarring in the anterior stroma, who is a long-term Fuchs patient requires a penetrating graft, not an endothelial keratoplasty. Do not do it when the chamber is too shallow. I've done this a few times with my surgical bravado, thinking I can get a button in that chamber, and particularly in Asian patients with very shallow anterior chambers, EK is not a good option. And when you have a situation in which you will not be able to sustain an air bubble. The advantages of EK over PK are numerous, despite cataracts and glaucoma. The special considerations for DSEK and concomitant or previous cataract and glaucoma surgery need to be taken into consideration very carefully. There's a much higher rate of dislocation and the need for secondary procedures in glaucoma patients, so you need to warn them and consult with your glaucoma surgeon prior to surgery. But it can be very safe and effective with both cataract surgery and glaucoma. So I hope that in the last 20 minutes I've given you some useful hints to help you through not just simple endothelial keratoplasty, but the most complicated cases. This is my last time addressing the audience here, and I'd like to once again thank Dr. Sanchez de Ita, to give my thanks to Enrique Grau Wichers and his son, Enrique Grau Hernandez, for their great friendship and for the important participation of Mexico in the Pan American Association of Ophthalmology. Thank you very, very much.